Well, good evening, everybody, and welcome to our 5th Acute Medicine webinar or #SAMinar. We've got a varied programme for you today. I'd like to thank you all for joining us, and we have people joining from all over the globe, and we are really appreciative of the people who are joining from Spain, Singapore, Australia. It's absolutely fabulous to have you all, and we welcome you into the SAM family. So I'm going to start off with just a quick look at the agenda, which I'm sure you've all seen. And then a quick slide just to let you know how to ask a question. If you go to the bottom of your screen, there is a question and answer box. If you ask your questions there, we can put them to the audience. You can also like other people's questions, and that uplifts the questions. So if we're running out of time, we can ask the questions that people really want to know the answers to. There's also a chat box down the bottom that if you want to chat in general, please let us know where you're from and what you think is going on. Oh, I've lost control now. Oh, here we go. So first of all, we'd like you to complete a few questions. We do this every week. So the first question should come up if Tim's got control. Can you just tell us who you are, please? Give you a few seconds, and then hopefully Tim will be able to show us the answers. Thanks, Tim. So good mix, mostly consultants, but nice to see some physicians associates, some other AHPs, nurses, and some trainees. Welcome, everybody. And move on to the next question, please. And the answers, Tim. So good proportion of Team Sam here, which is lovely to see, and everybody else is obviously very welcome. And the next question. And the answers. Oh, Tim, you've got some work to do there then. We'll look forward to that. And the next question. And the answers, please. Good, so hopefully we're all going to be informed on subjects that seem that not many of us are very confident on, which is absolutely brilliant. So I'm going to hand over to our first speaker, who is Dr. Tim Crooksley. He's an acute medic and works partly at the Manchester University Foundation Trust, but also at the Christie, which is the specialist cancer hospital. And he is going to tell us about COVID-19 in acute medicine and how it has implications for acute oncology. Tim, over to you.
Thank you very much, Sue. And yeah, and that's sort of part of what I'm going to do, but you know, it's a speaker's right to slightly change the title of the talk. So I'm going to talk about that, but then I'm also going to talk about some work that Sam's been heavily involved with nationally, which is developing a low-risk febrile neutropenia exemplar pathway, and how that may then fit into slightly to the COVID crisis and work going forward, which is clearly very important. I have no particular conflicts of interest relating to this talk. Ooh. So what I'm hoping to do here in the next 15-20 minutes is to sort of do a very brief overview of acute oncology, talk about COVID and particularly impacting patients with cancer, talk in general terms about some ambulatory management of acute oncology presentations, and then a brief talk about low-risk febrile neutropenia with some particular focus on the new pathway that's going to be published soon. And so I've lost the camera, so I apologize, but that's probably a blessing for all of you. So basically, acute oncology was designed to help a few things. It was to try and help improve the patient journey, expediting clearer pathways for diagnosis, liaison with treating oncologists, supporting inpatient care, and educating colleagues working in acute medicine and other specialties as to the developing challenges of acute oncology. And acute oncology is divided into 3 clear presentations. The first is type 1 presentations, and these are new cancer presentations, patients not known to have cancer presenting directly to the emergency department and acute takes for the first time. Type 2 presentations are those treatment complications relating to treatments from systemic anti-cancer therapies such as chemotherapy, immunotherapy, and targeted treatments, and radiotherapy complications. And then type 3 presentations are presentations related to the cancer itself, such as pleural effusions, ascites, malignant spinal cord compression. Sorry, this is screened. So at the beginning of this, back in April, the Acute Oncology Advisory Group produced some guidance about how we might manage some of these specific presentations and some overall guidance for COVID-19 triage. And we did this on the basis of each of the 3 different types of presentation. At the beginning of this process, oncology colleagues nationally prioritized various types of systemic anti-cancer treatment, depending on those that are of most benefit and life prolonging to those that are particularly palliative. And they were given prioritization between 1 and 6, 1 being those with the greatest benefit and 6 of those being with the least benefit, with a plan that as the pandemic increased, that we might have to reduce the level of prioritization and level of treatment the patient could access going through. And so with that in mind, for those with type 1 presentations, so the new presentations, this guidance once again reiterated the need for early discussions about patients who are unlikely to benefit from chemotherapy, and certainly those in whom chemotherapy would give the less benefit, in the hope that they weren't then going to be having less useful interventions, and that early symptom management and early discussions about appropriate escalation of treatment could be had, and that was emphasized in for those with type 1 presentations. In those with type 2 presentations, there wasn't much change in the standard guidance. In those who have neutropenic sepsis, we didn't suggest that people deviated much from their current pathways. There was an important reiteration that it was very sensible to try and manage patients with lowest febrile neutropenia as an outpatient, of which a bit more later. Importantly, one of the things we were worried about when we drew up this guidance was that there may be challenges in patients on immune checkpoint inhibitors who may present with breathlessness, and distinguishing whether these patients had pneumonitis or COVID. And we put a bit of general guidance with regards to that. This is all freely available on the web. And so we put some general guidance about how you might approach the patient with COVID and cancer who are on immune checkpoint inhibitors. And for type 3 presentations, again, we reiterated the prioritization. For example, in those with metastatic spinal cord compression, they were triaged so that patients who would potentially be for surgery would be a type 1 presentation, so they'd get very good benefit. For those who had salvageable neurology, that would be a type 2 prioritization, so again, we'd be likely to get it. Had the pandemic got severe and we'd reached a stage where we weren't giving type 4 treatments, then for those in whom the treatment for spinal cord compression was aimed at alleviating symptoms, those patients wouldn't be getting that treatment, though we never got to the stage beyond where we weren't treating patients who are prioritization 6. So unless there's a significant outbreak, all patients with spinal cord compression would be getting treatment. But this pathway help explains to colleagues how they might sort of do that if they were seeing people. And then for the type 1 presentations, we know that nationally and internationally that the number of people in the short term presenting to emergency departments and acute takes with a new presentation of cancer has reduced. The top left figure is the figure there for NHS, from NHS England, and you can see the number of cancer patients starting treatment, and you can see a significant drop off in April 2020, and the numbers even lower for May 2020. This is an international finding, and as you'll see, there's a paper there from Lancet Oncology showing very similar things happening in the Netherlands. So what actually happens in people with cancer and COVID? Do patients with cancer who develop COVID-19 do particularly badly? Well, people were very worried by this initial paper coming out of China, which was published in Lancet Oncology earlier in the year. And this was a prospective study of 1,590 patients who were diagnosed with COVID-19 in China. And it looked at those patients with cancer and found that they had a significantly increased likelihood of a poor outcome, i.e. they're either going to have invasive ventilation or death. And the outcome was 39% of patients with cancer and confirmed to have COVID died, compared to 8% in the general population. So a significant difference, but important to note that even though this was published in a cancer paper in a cancer study, there were only 18 patients with cancer in the group, and there was a very wide heterogeneity of tumor types. So difficult to suggest from this data that cancer patients do worse. A similar paper published in Annals of Oncology, again from China, looking at a perspective, but again only of 28 patients. So really very small numbers of patients here. The biggest single data set up to last week, where the UK coronavirus group published their data, was here out of the one place that's been hit very hard with cancer patients, and that was Memorial Sloan Kettering in New York. This is their data for the first 423 patients coming through. And they found that, and this has been shown in many papers, that patients who have hematological malignancy in COVID have particularly poor outcomes. And then things that aren't surprising: older age, which has been across all populations associated with worse outcome, lung cancer, particularly in smokers, lymphopenia, although that's not particularly uncommon in cancer patients having treatment. And then they found in their cohort that patients being treated with immune checkpoint inhibitors did particularly badly, although that hasn't been borne out from the data from the UK coronavirus group. So again, at this stage, small numbers, sparse data and conflicting data, but there is a sense, particularly in those patients with solid tumors receiving SAC, that their outcomes if they develop COVID-19 are not as bad as people feared they were going to be. Indeed, they are better than many other significant comorbidities. So perhaps COVID in cancer patients isn't as severe as we thought it was going to be, but nevertheless, we're going to have some challenges going downstream, because we know we're going to get more patients presenting late with cancer now. We know that from the reduced diagnoses, and there's going to be an increased challenge in managing the acute oncology workload that waits for my oncology colleagues. And I don't need to persuade any colleagues in acute medicine that we're likely to have some challenges facing us this winter. And one of the main ways we're going to keep the system afloat is by using ambulatory care, or SDEC. And there are many acute oncology presentations that are amenable to having ambulatory care. And these include malignant hypercalcemia, chemotherapy-induced nausea and vomiting, plasma-related AKI, some of the more low-grade toxicities from immunotherapy, and the endocrine toxicities such as hypophysitis and immune-mediated diabetes, not immune-mediated DKA from the fantastic presentation from Dr. Coombe last week, but other things that can be done. And then two things I'm going to talk about in a bit more detail: incidental pulmonary embolism and low-risk febrile neutropenia. This is a position statement, an international position statement, this paper from colleagues from the UK, the United States and South Korea, of which Professor Lasson, who gave us a fantastic talk at the beginning of the webinars, was one of the co-authors. An incidental pulmonary embolism is when patients are undergoing routine imaging and are found to have a pulmonary embolism where they're asymptomatic. And we have a pathway here at the Christie where our radiographers diagnose that, and then they are admitted to our ambulatory care unit, and they are started appropriately on low molecular heparin after a clinical assessment. One of the new challenges coming through COVID is that we now have this new entity of incidental suspected COVID-19. We have a number of patients coming along for their routine follow-up staging CT scans to see how their cancer treatments are working, and we have pictures like this. And so we quickly developed a pathway where our CT radiographers would obviously recognize this much better than I would, and would then contact the ambulatory COVID assessment unit for a clinical assessment. And what we were routinely doing at this stage, and we are doing at the minute, is a clinical assessment, including some exertional oxygen saturations, some standard routine blood tests. Obviously, we're going to do a screen for SARS coronavirus 2 and other infective respiratory pathogens, because that's often the cause, particularly in patients with cancer. We've recently started doing an antibody test, so that wasn't available obviously initially. We start them on some empirical antimicrobial therapy, and then we follow them up through a telephone triage system, which we've been operating for all our patients with COVID who are on chemotherapy. But what I really want to talk about a little bit more is we really need to try and move forward with some ambulatory oncology work, and nothing is better placed for that than the management of low-risk febrile neutropenia. Unbelievably, this paper published in Annals of Oncology, a meta-analysis of outpatient management of low-risk febrile neutropenia, is now almost 10 years old. And it really was the sort of landmark meta-analysis that showed that actually the management of low-risk febrile neutropenia as an outpatient is safe and effective. This was meta-analysis of 14 studies, which was in 2 parts. The first part looked at patients managed as inpatient and outpatient with low-risk febrile neutropenia, and there was 13 deaths out of 742 patients, but no difference between the inpatient and the outpatient group. And then secondly, in 8 studies with 857 patients, looking at outpatient all antimicrobial therapy and outpatient intravenous therapy, no difference and no death in those patients. So how do we assess if people have low-risk febrile neutropenia when they present with febrile neutropenia to our acute medical unit? Well, there's 2 validated risk scores. The first is the MAS score, which colleagues I'm sure will be familiar with. This looks as a 26-point score, and if you score 21 points or more, you may be then suitable for outpatient management. This is a score that's used when you bring people in, and you can use that to assess whether you think they're low risk or high risk. The CISNY score, which is the second validated score, works somewhat differently. This is a score that would validate your clinical judgment if you thought the patient was well enough to go home. So if you see a patient on the acute medical unit with a solid tumor, it's not validated in liquid tumor patients, and you felt that you could go home, you could then do this to validate your score, to validate your decision. If the patient scores 1, they would be low risk and suitable for outpatient care. If it's 2, it's intermediate risk, you need to think again. If they score 3 or more, they should be kept as an inpatient according to the CISNY score. Which is better? Well, they're both very validated. This was some data of 571 patients with febrile neutropenia in the UK, South Korea, and the States. And it looked at both the MAS score and the CISNY score, and both had reasonable discriminatory value in predicting which patients with low-risk febrile neutropenia would run into trouble. Importantly, it notes that, again, clinical judgment alongside these scores is clearly very important and should be utilized rather than blindly following scores, as we all know. For those who are trying to make a case to their managers that they need some pathways for low-risk febrile neutropenia, this paper comes out of the Peter Mac in Melbourne. This looked at only 25 patients managed in a 12-month period with low-risk febrile neutropenia in an outpatient setting, in an ambulatory setting. And with those 25 patients, they made savings of 71,000 Australian dollars, which equates to £40,000. And that's for just 25 patients. So it's actually only needs a very small number of patients to make this a viable option. And when you're thinking about setting up low-risk febrile neutropenia pathways, there are clearly other ambulatory oncology presentations that we discussed earlier in the talk that you could use alongside those to broaden the scope of the clinic. And you may be fortunate enough, as we have been here, to persuade colleagues from supportive and palliative care to support you with that, so that when the patients come back through an ambulatory care setting, they not only get acute medical input for their acute problem, but they can also get ongoing supportive and palliative care, should that be required, to try and prevent further downstream problems. And this has been a very useful method that we've developed here with acute oncology, working with supportive care and palliative care colleagues to help keep people being managed in an ambulatory setting. The managements of ambulatory care are well known to everybody on this call, and they don't apply any differently to those who have low-risk febrile neutropenia. But it's a challenge. It's not widely done in many centres in the UK. So our National Acute Oncology Working Group have designed and are about to finish an exemplar pathway. We're about to publish exemplar pathway for patients presenting with low-risk febrile neutropenia. And it gives hopefully some guidance which then people can adapt to their local services so that they can facilitate the management of low-risk febrile neutropenia. And within the packet, it gives you a standard way of how we do that, some of the pitfalls of how not to do it. And within this, we've also given people an ambulatory discharge checklist, which will hopefully be helpful. And we've also given an exemplar patient information sheet for those who are going to be managed with low-risk febrile neutropenia, to explain why they're being managed in the community and some of the things that should bring them back. So it sort of forms part of the standard thing that oncology patients are very familiar with, and that's patient information cards and how to contact local hotlines. Of course, not everyone who scores low with their MAS score should always be sent home, and clinical judgment is very important. And hopefully, to end this, a very brief clinical vignette to sort of try and remind colleagues that clinical judgment is always very important. This is a lady who came in a few weeks ago in the middle of the COVID situation. So she's a 55-year-old lady with a very early stage rectal carcinoma. She was on long course chemoradiotherapy and was receiving radiotherapy alongside capecitabine, which is a normal chemotherapy drug. She presented to our unit with fever, oral pain, and loose stool, and she has no other significant medical history. On examination, she's comfortable, and she has some low-grade fever. She's hemodynamically stable, but she has grade 2 oral mucositis and some plantar erythema. The rest of the systemic examination is unremarkable. Her bloods at this point showed to have a grade 4 neutropenia with an absolute neutrophil count of 0.4, thrombocytopenia, and she was treated initially with intravenous antimicrobials, fluids, antiemetics, and some mouthwashes. Her MAS score was 24, which would suggest that she would be suitable for outpatient management, but she was seen by the on-call acute medical consultant who felt she should be observed overnight, and some further blood tests were sent on the basis of their clinical suspicion. Unfortunately, webinars are not interactive, so I can't ask what colleagues think now, but certainly I know there's a couple of oncologists here and they will know what this is all about. We see her the following morning. She has ongoing loose stool, no further fevers, but she's now struggling to take any oral intake, and she has significant worsening of her oral mucositis with a drop of her neutrophils to 0 and a further worsening of her thrombocytopenia. She had an urgent PICC line inserted. She was commenced on TPN, commenced on G-CSF, which is never indicated in patients with low-risk febrile neutropenia, and was commenced on uridine triacetate. So colleagues will now know this is a case of Dpd deficiency. Uridine triacetate is a very expensive treatment. It costs £70,000 for a course, so you have to have very strong clinical suspicion before you start it, but it's a very, very safe and good treatment. And here is a review of the use of uridine triacetate, which is for patients who have Dpd deficiency and inability to break down fluoropyrimidines such as 5-FU and capecitabine. And you can see here that started early in patients that have expected lethal toxicity, that recognized early and treated appropriately. Uridine triacetate can help improve outcome in those with potentially fatal, indeed expected lethal capecitabine toxicity secondary to Dpd deficiency. So in conclusion, the actual specific impact of COVID in cancer remains unclear. There is clearly going to be a huge amount of work because there are now delays in new cancer presentations. In order to make this more sustainable in the next couple of months, there'll need to be an increasing use of ambulatory care and acute oncology presentations. And as always, collaboration between acute medicine and oncology remains essential. Thank you very much.
Thank you very much, Tim. That's exactly 20 minutes. You were right.
There you go.
So we've had a couple of questions come in, and I've got a couple of questions that I might start with mine, if you don't mind. For the acute medic in general, neutropenia is pretty scary, and I suspect there is, despite the good evidence that you've presented, there is a lot of people who would feel, quite difficult about sending patients like this home. And I think for people in sort of a general DGH type hospital, the ones we tend to see are mainly hematological malignancies. And the hematologists are very, very conservative, and the thought of us saying, well, we've done a score and we'll send them home, I can just imagine the response. How do we get the hematologists on board? Because it looks like it's massive cost saving and it's obviously better for the patient.
Hematology patients who are often high risk febrile neutropenia due to the fact that they have prolonged periods of neutropenia. So that it would be unusual, although the mask was validated in hematology patients are usually high risk. And so I'd be very anxious, particularly if you're starting out, about trying to incorporate a huge number of hematology patients, though in the select group it's very safe. It's certainly much safer in those with solid tumours, particularly those in whom you can predict are going to have a very transient period of neutropenia, and carefully watch these patients have a very good outcome. So in the first instance, colleague would be much safer focusing on solid tumours until they get some more experience of managing low-risk febrile neutropenia as an outpatient, and then perhaps work on haematology colleagues who are understandably and rightly more cautious, particularly as the evidence in haematology patients, although there is not as strong as those with solid tumours.
Thank you. There's a couple of other questions come in. Dr. Scriven says, you mentioned finding COVID on staging scans as in an incidental finding. Is there any data on the incidental cancer pickup rate of people having scans for COVID?
I've not seen any, and it's incidental suspected rather than confirmed. Indeed, the actual people who are found to have COVID in this cohort that we've had is actually very small. I have absolutely no idea about the numbers of patients who are having scans, chest CTs for COVID who are found to have a tumour, but I suspect it will be similar numbers to those who have CTPAs and are found to have an incidentaloma or a small tumour. So I doubt the figures are greatly different, but I don't know, and I've not seen any data relating to that.
And another question, what has been your experience of people presenting acutely? Have they been delayed presentations as they're trying to avoid coming in during COVID? I think this is something we've all seen in acute medicine.
Yeah, I think that's right. I don't think, absolutely the answer to that is yes, but I'm not certain that the cancer population is any different from the general population. We've had, as I'm sure all colleagues have, a number of patients presenting here who have been ringing 111 regularly and told to stay at home and self-isolate, to then arrive very unwell. And that's the difficulty of initial telephone triage without having seen the patient. I think telephone triages are not a much easier thing to do once you've seen people and know them. I think trying to do it having not seen them is a much more challenging thing to do.
Yeah, I agree. And a final controversial question from me, because you know I like to be naughty. Have you seen the Goldacre data about relative risk of various things? Because your data showed that in oncology patients that smoking was detrimental, but the Goldacre data showed that smoking was actually beneficial, in inverted commas. I'm not suggesting we'll go and start. Any ideas why and what's going on?
Well, I think what we have, and this is also controversial, Dr. Crosland, and I won't forgive you for making me say something controversial, is that we have a lot of data and a lot of things being published yet with lots of very contradictory findings. And what we'll need to do really is settle down and actually examine some of these things in a bit more detail. The findings already just in the oncology field for COVID about whether immune checkpoint inhibitors have a difference, whether chemotherapy has a difference. There's already conflicting studies, and we can say similar things for the treatment of hydroxychloroquine. I dare say in a few weeks' time we'll have a study that refutes the findings of recovery with regards to dexamethasone. So I think we're going to continue to have lots of varying studies with lots of varying outcomes, and it'll be difficult at this early stage to piece it all together.
That is an excellent answer. And with that, I'm going to hand over to you as co-chair to introduce the next speakers. Thank you.
And I'm at work, which is my excuse for still having to wear scrubs, but some other colleagues should follow the example of Dr. Lamb, who's an F1 and brilliantly suited and booted, and he's going to tell us about effective discharge and suitable follow-up plans for acute medical patients. Thank you, Dr. Lamb.
Hello, my name's Chon. I'm an F1 in Cardiff, and my presentation is our quality improvement project about the effective discharge and suitable follow-up plan for acute medical patients. So some background, in our medical emergency assessment unit, we have some patients, they're called day returners, and these are patients who are discharged from our unit with a follow-up plan to return to the MEAU within 1 week. Now, these patients are typically seen by medical registrars and with consultant input as necessary. For our hospital, before the project, there was no protocol in place. All day returners were accepted up to a maximum of 6 per day. Now this raised 2 important issues. Firstly, for trainees, there was concerns about too many and inappropriate day returners, but also for patients who have the inconvenience of multiple trips to the hospital, whether that be in a sense of childcare and arranging more childcare, but also taking time off work. And our solution to this was a poster and an audit. Our audit aims. Our primary aim was to determine if referrals for day returners are being carried out according to local hospital recommendations, and with a secondary aim to determine whether discharge summaries were completed for our day returners. And the overall objective of our QI project was to see what can be done to improve the current situation. So what we actually did, data was collected retrospectively. Our initial audit was a 2-week time period in August 2019 and re-audit in November. Now, viewers will know that this is pre-COVID. And our audit population was attained by looking at our MEAU diary, which just a bit of background in terms of what we had in our hospital. For day returner patients, for those who we want to refer as day returners, we got a patient label and then we stuck it in into the diary in the MEAU reception under the date for which we would like the day returner patient to come back in. And it's from this diary that we obtained our patient population. Our intervention was an MEAU poster, which is on the next slide, and that was displayed from September 2019 onwards. In total, 85 patients were collected. 85 patients' data was collected. So this is our poster. Essentially, what you have is on the right-hand side, you'll see clearly listed are the alternative avenues for referring patients that may have otherwise come in as day returners. Now these include various things that you can see on the screen, but also on the left-hand side, we gave some pointers about which kind of patients we thought would be considered an appropriate day returner and which patients would be considered to be unsuitable day returners. I wanted to pay particular attention to our GenMed 36 clinic. This is an acute physician clinic which we set up, which allowed patients to be referred to this clinic instead of being referred as day returner, and these patients can be seen within 6 weeks by an acute physician. Our audit results. On the left-hand side, you can see that there was an improvement in the percentage of appropriate day returners in the re-audit, but that there is still a long way to go. Now, examples of inappropriate referrals, which viewers may have also observed at their centres, the commonest was non-urgent blood tests, and these included blood tests for warfarin dosing, for INR dosing for patients on warfarin, and we have a specific service for this. That's not the day returner service, but also for non-urgent imaging. So these are patients who may be suspected cancer, and a better alternative would be to refer them to their respective cancer pathway. Now, on the right-hand side, you can see that there was an increased, there's a higher average number of day returners in the re-audit. Now, several reasons, several possible explanations for this. The initial audit was done in August, in the summer months, where generally there are fewer patients coming in, but it's likely to be multifactorial. We ran some statistics on both these, on both the data sets, on this data set, on both graphs, and the results were not statistically significant, likely due to being small sample size. In terms of our secondary audit aims, there was also an increase in the percentage of completed discharge letters in the re-audit. This was once again not statistically significant and is likely to be multifactorial. So in conclusion, our intervention increased awareness of follow-up services and clinics in the effective discharge and follow-up of day returners. Now, going forward, what we do, so this audit was done pre-COVID, and the situation has changed significantly since then, and we will likely need a re-audit and evaluation of day returner service. But also, in terms of concrete plans going forward, you'll see that we want to do two things. We want to improve service provision. Now, what our acute physician clinic let us do was that we could see what pathologies were commonly coming in to the acute physician clinic. And then we could set up new services based on what the demand is. So for example, on the right-hand side, you'll be able to see in small print, there's an AKI hot clinic, which is set up because there was a lot of patients coming into our GenMed 36 clinic with, for AKR-related reasons. Also, secondly, we want to improve staff utility of services, and hence why we created this day returners form on the right-hand side. But ultimately, we would like for the whole system to go electronic. At this point, I'd like to thank you for listening, and if anyone had any suggestions for how we can improve things further or any questions, I'd be very happy to take them. Thank you very much.
Thank you very much indeed, Dr. Lamb. Can I ask you, following our earlier talk, are you going to think about putting lowest febrile neutropenia into your potential, add that as an extra presentation that could go into your UHL day returners form?
I think we can certainly look at the data in our local centre in terms of our local realities to see how that could be achieved. But I can certainly relay that back to the department bosses and see what we can do.
And then there's a further question here from Liam Barker, who asks, are the indications for referral included at induction?
And by induction as in when they actually get referred. So
when I presume it's, I presume, and I'm sorry, it wasn't, but I presume that means for sort of staff when they're starting in your unit or starting in the hospital. Is it clear which patients come onto that pathway? I think is probably the question. Is it part of your induction process for staff?
So when I started, it wasn't, and we're looking to see how we can incorporate that into the induction process.
And a second question from Miguel Marimon, who asks, how many discharges were there per day and how many day return patients were readmitted?
Discharge per day. I had the data for over the 2-week period. In the initial audit, there were 245 discharges, and in re-audit, there were 279 discharges. And as I said, we only allowed a maximum of 6 day returners per day, so there were no more than 6 per day.
That's wonderful. Well, thank you very much indeed for your time, and thank you for presenting. You did a wonderful job, so thank you for that. Great pleasure to introduce our next speaker, who's Dr. Chris Sube, who's a consultant in acute medicine from Bangor. Not only is he a consultant in acute medicine, he is an international leader in patient safety, published some of the first papers on early warning scores, and it's a great privilege to welcome him this evening to talk to us about one of his latest projects, which is using apps for patients in acute oncology, safe at home. Thank you very much, Dr. Sube.
Hi, good evening, and thank you very much for the invitation.
Sorry, Chris, we've lost you. So what we'll do is we'll just pause and hopefully our colleague will be able to get you back. And if Dr. Sube could start again, that'd be very helpful. Thanks, Chris.
Hi, good evening. And thank you very much for the invitation. It's a great pleasure to be here tonight. I need the next slide now, please. And the title of my talk is Using Apps for Patients in Acute Oncology Safe at Home. And this is a project that I undertook as part of an Improvement Science Fellowship with the Health Foundation, and this was supported by an I grant from the Welsh cancer charity 10 of Us. Next slide, please. I would like to start with a case story, which is not that atypical, and many of you might have seen similar patients. This is a 32-year-old patient who presented to our local unit. A patient who was on treatment for metastatic melanoma and had achieved 3 courses of checkpoint inhibitors, combination therapy with ipilimumab and nivolumab, and had then developed diarrhea up to 10 times per day, including at night, no blood or mucus, and presented to our local emergency department. There seemed to be something very strange in that lots of patients who are not being treated locally seem to want to go to North Wales to have holidays here in between cycles. So we're seeing patients from other centres very regularly. But this patient was seen in the emergency department, was told that this was likely to be overflow diarrhea, and was asked to go home and present to his local council, happens to be Tim's Hospital at the Christie, if he was concerned about anything. Now, this patient was concerned, and so he returned to Manchester and presented there. He had some blood tests which showed a mild eosinophilia and a slightly raised CRP, an abdominal film which was not particularly remarkable, but a subsequent CT showed mild colitis. He was treated with IV methylprednisolone, and when he didn't resolve, with infliximab. So a story of a patient who suffers a side effect from treatment, and who has got some knowledge about this treatment and does the right thing by asking for help. And I think more often than not, patients are part of this. Next slide, please. Tim, I don't seem to be able to control the screen. So if we're looking at safety of healthcare in general, but particularly in the powerful drugs that we're giving for treatment for cancer, that it's worth to have a look at the principle of this safety. The first principle is that a lot of the side effects that we're seeing are in fact predictable. We know which drugs cause what type of side effects, and in fact we often even know when these side effects will occur, when patients will develop neutropenia and other side effects. Some of the side effects are preventable, and sometimes it's not the severe side effects so it's not all side effects that we can prevent, but we can make side effects become less severe if we intervene at an early stage. And then the certain principle that I illustrated in the case story was that the patient or their family often have got some really significant insights on what's happening and are able to help us with those. Now, if we want to use this to design interventions, then it's worth to look at what the Behavioral Insight team has published and the principles of this, and that they say if you want to change somebody's behavior, and that's in politics or in medicine, if it's healthcare professionals or patients, then the intervention needs to be easy. It needs to be attractive to use. It needs to be social, and that needs to connect people, and it needs to be timely. It needs to be in relation to the event that's happening. Next slide, please. So this led us to this project, Keep Me Safe, which has got this underlying principle that safety is always a network. So we had a grant with 10 of us, and Galactic is the technology company that helped us to design this intervention. Next slide, please. So I'm going to show you results of a literature review of oncology applications, the design of the application, and the results of the trial. Next slide, please. So if we look at the landscape of NHS library of apps, there's at the moment actually 6 apps now. There's another 2 since I've done this slide for melanoma and 1 for lifestyle. But this is what you find for cancer forward. And so OWISE is a slide, is a application for breast cancer, and the evidence for that, forward please, is like this. So 15 patients participated in focus groups, 8 of those registered symptoms, and 4 thought this was a useful application. Now this is an application that's got funding of 7-figure sums behind it, but that's the evidence that they provide. Next slide, please. So we undertook a review of the literature, and we looked for interventional studies that had used mHealth applications for management of cancer. Next slide, please. And what we found is that there's a lot of stuff published, but a lot of it's feasibility studies or technical descriptions, but very, very little on actual outcomes, so showing what helps patients. Next slide, please. And what was particularly interesting was, if you want to have something that's relevant to your own healthcare system, a lot of it is stuff that's from the USA. Compliance is often not reported, and we often don't know whether the patient actually liked what they were doing or found it cumbersome. Next slide, please. So in order to design an intervention, we conducted focus groups. We deployed a technique that's called scenario-based design. where we used use cases of patients, and with the focus groups walked through those cases and had a look what complications might occur and how those patients would interact with an application and how that would help them to maneuver their illness. We came down as a methodology to design of checklists for patients, something that we published on previously, and then undertook a prospective feasibility study. Next slide, please. So checklists are a useful tool for all sorts of things, but we were particularly encouraged to use this technique because the UK Nursing Society has published checklists for healthcare professionals, and this is what acute oncology nurses will use if patients with cancer have got complications and ring helplines. And what you can see there's a long list of different questions over 2 A4 pages, and depending on the answer of the patient, those symptoms are classified as green, amber or red, with red usually leading to an intervention such as hospital admissions, amber often leading to an intervention, and green usually being followed by generic. Slide, please. Next slide, please. Slide back. So from this, we generated an application for patients with checklists with 9 groups of symptoms. The patient would get a push notification every day to complete their checklist. Now, the special thing is that we used networks. So we used networks to link those things up the dashboard for clinicians, but we also linked the patient to a safety buddy. So a friend or family member that would get a push notification if the patient was unable to complete their checklist, or if the checklist indicated the symptom that was amber or red. The patient would get a telephone number to call if they had an amber or red symptom, and it was the prerogative of the patient to use that telephone number or not. But the clinicians could see the next morning on the dashboard whether there has been a concerning symptom, and were able to then contact the patient. The whole thing is embedded into a contact management system. This looks a bit like a Lego system in that you can change building blocks out of these checklists depending on what type of treatment the patient is. So there's some very specific side effects to some drugs, and so you can take a checklist element out and insert another checklist element to tailor the content of the checklist to the patient's symptoms. The whole system is anonymized for security. Next slide, please. So the study was run over 60 days. We looked at patients' anxiety, depression, the functional assessment for cancer therapy questionnaire, FACT, beginning at 30 days and at 60 days. And in terms of clinical outcomes, we looked in essence on health economic outcomes, such as days in hospital, the number of outpatient appointments and GP appointments. Now, this is a feasibility study, and I'm going to show you some of the results to show that it's feasible. But in terms of clinical outcomes, we were not powered to show results. We were able to show that there was improvement in anxiety and depression, but that was not different from the control and the intervention group. Next slide. Next slide, please. So we recruited 100 patients, 197 that we approved. The control group was slightly older than the intervention group. The groups were gender matched and matched for the cancer, breast, bowel and lung cancer were the predominant groups, and for performance status and type of treatment. Next slide, please. Now, what we found encouraging was that patients were actually using the app nearly every day. So per week average over 6 usages, and the friend and family chipped in and also used the app on most weeks. And so overall we had 3,200 users over 60 days. Next slide, please. Did patient like the application? They did, and they gave us lots of information. So this is the information from the checklists. Exhaustion was the most common symptom, followed by nausea, fever, chest pain, sore mouth. And the worrying signs like fever and chest pain were relatively rare compared to 3,200 usages. Next slide, please. Out of a Likert scale was 1 to 5 points. Feedback from patients and relatives was good. They found the information of the hub helpful. They liked the link to relative and friend into healthcare, and they indicated that they felt safer with the checklist. Next slide, please. And this is some of the feedback that was collected within the app in the same format. Next slide, please. So discuss what we've shown so far. So if you look at healthcare interventions, you can evaluate this at micro, meso, and macro level. So the micro level is between the relationship between the patient and the immediate healthcare team. And we found high acceptability both within our local oncology team and the patients and family members that supported the patients. The larger team level, at the meso level, we found that you probably need to do some workflow changes, and some of them are positive in that you can pick out patients a bit earlier that might develop complications, and we had a strong trend towards less usage of hospital days in the intervention group compared to the control group. And it allows you to structure your workload in the team in a more proactive way. Now, we don't know how this pans out if you do this at macro level, so at the health economy and larger organizational level. But you could, for example, envisage that smaller units could chip together and have a dashboard that's shared between different organizations, and that allows to be more effective and efficient in the usage of proactive identification of side effects of patients. This will require a multi-center randomized control trial that we're currently planning. Next slide, please. And just to say, there is evidence in the literature to support this principle of agency to patients. So if you measure quality of life and you allow patients to do that and share that with clinicians, then actually their quality of life is more likely to improve than if you don't do this. And this is a study that was published in the Journal of Clinical Oncology already 16 years backwards. Next slide, please. I want to use the last minute to do thank yous to our amazing patient reps, Val Wakefield, Betty Foster, and David Thomas, our acute oncology team, and our friendly help from Philippa Jones from Macmillan and Tim, who acted as advisors and co-applicants on the grant. Next slide, please. I also want to do 2 plugs. We've got a webinar on acute medicine on the 2nd of July, instead of our usual summer school that we do in Wales for our acute medicine trainees, and we got an amazing cast. Kenneth Rockwood, Matt Morgan, Trish Grenell, Owen Williams, John Glenn, and Mark Talbot, many of who you will probably know from BMJ and other publications, will speak at this meeting. Next slide, please. And my last plug is for my own unit. If you look across the Menai Strait there in the background, you've got Snowdonia. Between the water and the mountains, that's where my hospital is. And I'm actually sitting quite close to these cows at the moment, though not in the same room. Next slide, please. And thank you for listening. And I'm happy to take questions.
So it should be Dr. Crossland, please, Tim, who's now taking questions. Sorry, thank you.
Oh, we can double team. Chris, that was an amazing talk, and thank you. I just want to apologise to everybody for our technical issues, which seem to be ours tonight, and I apologise wholeheartedly. For some reason, we're struggling a little bit more with technology. Despite that, though, Chris, you did a brilliant job. I've put a naughty comment on the chat about finally apps that we can all believe in. You know, we all know about Max the app, but it's oh, and Nick's just popped up with a question as well, saying, "Great talk. What do you think about the track and trace app?" So apps are really important, and obviously technology is becoming more important. Hopefully, we'll get a little bit better at it. What do you think about track and trace apps and the use of other apps in general, as well as the one you just told us about?
I think in very broad terms, I'm a technology enthusiast and I'm an early adopter, so I'm interested in trying things out. But I think the digital health has to follow the same principle as all other interventions in healthcare. So it needs to be tried and tested. So we are in the early stages of developing apps for healthcare professionals and in this particular case for oncology patients. And I think it's our job to prove that this is a better way to care for patients that's more appreciated and actually gives outcomes in better quality of life, less complications and less cost. The track and trace app, I think at the moment, the way it's been presented has got significant problems, both from the technology and the trust that you have. And I think one of the things that I firmly believe and that a lot of the digital technology requires us to trust the technology and those that provide it. And if that's not there, it's going to be very, very difficult. You probably followed the news, and the Germans have launched their app 2 days ago. They've got several million downloads already, and they've chosen a system that cannot be centrally controlled. And I think that will engender more trust into the system, and that's maybe something that should be considered.
Another question. I don't know if I misunderstood your slide, but your participants, you said 100 out of 197 agreed to participate. Is that right? What were the reasons for not wanting to participate? Was it technophobia?
I mean, some people didn't have a smartphone, and some didn't feel that they have the time, and obviously this is a very emotional time while you're undergoing cancer treatment, and so to be taking part in a trial might not be everybody's cup of tea. Having said that, I think a recruitment rate of 50% for a trial is very, very high. So in that sense, I'm satisfied that this is likely to be viable at larger scale. And I think the other thing that's been encouraging is that people on the whole stuck with the usage of the app for the 60 days trial period, and many wanted to continue to use the application after we were trying to close down the trial, and asked us whether they could use it even if it wasn't linked to a clinician dashboard. And so I think that's hopefully some indication that we're on the right path, and that's worth to pursue that.
And another question's come in from Dr. Alim. Excellent idea. Have you had problems from the GMC for patient confidentiality? I'm assuming he means GDPR, and keeping patient records secure with these apps.
So this is a formal study that's gone through research ethics and has been sort of examined by that, and we've certainly had questions about this. I think that's not unusual. I do a reasonable amount of research with using digital technology. So the confidentiality in this app is, I think, less controversial than you think, because we're using checklists. We're not giving any symptoms out, and even the next of kin who might get a message doesn't get a message with a symptom. They only get a message saying you might want to contact your family member. So we've been extremely discreet with this, and this is not linked to broader patient records. So in that sense, it is fairly secure and probably securer than many of the paper records that we're currently using.
The next one is more of a comment than a question. As more and more patients become tech savvy, apps will take on more and more relevance, and there'll be a much higher take up in the future, no doubt. Have you thought about how else you can use your apps in a more virtual post-COVID world? I'm just thinking about doing the whole of ambulatory care on apps now. What do you think of that?
And I think this is one of the unwanted side effects, I guess, of COVID, that there is a real appetite now to use the technology that's been there for such a long time, and that the NHS has been so slow to adapt. And so I'm hoping that it might not be in apps, it might be on desktops, on other mobile platforms and technologies. But yeah, I hope that will allow patients to do things in the place that they want to be, in the way that they want to do, rather than having to trail around the country. I mean, especially in the area that I work and many others work in rural health. I've got patients who have to travel for 2 hours before they see me, and in many cases that is meaningless.
Yeah, it's really important the more rural you are, isn't it, that we can sort of connect with our patients even when they're not physically there. So that's all the questions we've had. Thank you very much, Chris. That was fascinating.
Oh, now I've got my amazing previous registrar, Alice. Hi, Alice. Good evening.
Following big footsteps, Chris.
Oh, Chris can even
How
do.
exciting. Looking forward to your talk.
Oh, thank you.
So we have indeed got Alice next. She's an ST4 in acute medicine, and she's going to talk to us about the teaching tombola, which everybody knows that I love teaching, so I'm really looking forward to it. So off you go, and thank you, Alice.
Thanks.
Don't forget to press on your screen first, and then you can forward your slides, unlike your mentor.
Thank you. Noswaith everybody, and good evening. I'm very excited to be following Chris tonight's talks, and I'm going to be presenting an educational change project, which I completed last year in my critical care rotation. I'm hopeful that it will be a transferable skill to medical assessment units as well, and especially in these more challenging times. I'm soon to complete the postgraduate diploma in medical education, so forgive the educational lingo and the QI methodology mixed in, but hopefully it'll be useful for everyone. So firstly, a little bit about context. The critical care unit in Cardiff has over 30 beds for level 2 and 3 patients in a tertiary care setting. And as a result, it attracts a wide range of trainees from different clinical backgrounds. And that means, from an educationist point of view, it's a thriving environment to train people. Dr. Tom Holmes, who co-authored the project, is a consultant leading in education in Cardiff and has already implemented a number of useful changes for daily teaching before handover every morning, which has proved quite effective so far. Topics were introduced, allocated to junior doctors on a monthly rota, and feedback for that was quite ad hoc. And as we all know as teachers, feedback is what helps us grow and develop our teaching style and also benefits our learners. So that was something that could potentially be improved. And my observations from my first few weeks in Cardiff were that actually discussions about how we could improve the process overall for feedback was important. And as with any change project, you'll be familiar with the concept of drivers for change, which are the purpose and the reason why you do something to help then do it and sustain it going forward. So in Cardiff, the main internal driver for change was the team focus, and that was led by a very supportive group of consultants that produced a form of dynamic club culture in educationalist terminology, which meant that trainees felt safe, they felt supported, and they felt keen to have a go and join in without fear of criticism from their colleagues. And then the external drivers, so the pressures on us from outside our little family community on critical care, were reflections from previous trainee satisfaction surveys, which suggested that teaching and training and feedback could be a bit improved, and that also links into recruitment for the wider specialty. Having thought about these drivers and how I was going to overcome them, I came to some ideas about a quality improvement project, and in particular the aims to increase quality and quantity of feedback from morning teaching for trainees, trying to get a bit more learner focus rather than the top-down hierarchical approach that's been the old-fashioned didactic method of teaching. And I planned to use online learning tools to collate feedback forms and generate quantitative data to see how successful that's been. I hoped that eventually trainees would get extra value added from being given feedback and portfolio supplementation with certificates, and I offered to be taken advantage of for teaching observations assessments as well, which hopefully kept them engaged. I plan to do that over my placement block, which was 6 months. This is just a quick slide shot of the evidence. There was no initial formal teaching feedback process at all really when I joined, and that meant that good practice couldn't be rewarded and good preparation couldn't be taken advantage of either, and equally any errors might not be picked up on, and people need to keep learning and keep developing. And I reflected that that potentially lack of engagement before my project meant that whatever we did had to be easy, generic and accessible, and to use Chris's analogy, EAST, although I can't now remember what they stand for, but that's a great way of trying to change behaviour. So I decided to use SurveyMonkey, 3 questions, free text, no Likert scale tick boxing, because I know that's what it is to us all eventually, and to post those QR codes around doctors' offices to try and make it easy, a quick scan with your phone, timely feedback, and then job done really. My best bit, the bit I was most proud of, was the loyalty cards, which are a bit maverick, but essentially they are coffee card style stamp cards. Every junior doctor gets one. They stamp it every time they provide a feedback form, and when you've managed to collect 10 stamps, you win the privilege and the luxury of drawing a prize from the teaching tombola. And this next slide, oh, you can't see it behind me, but you can see my colleague Hattie's beautiful face. She's given my permission to repeat this picture when she won the medical education specs from the tombola, and you can see the tombola card there as well at the top. Helpfully, the bingo stamps I bought were red, so it was red hearts on the critical care green, which looked really smart. In terms of data, the absolute numbers here are obviously quite small, given that at least 10 trainees were in the department at any one day, but overall you can probably say there's a positive trend there. The first upstroke reflects my own enthusiasm, my championing of my new educational baby, if you like, and also the fact that the team were very enthusiastic about the idea. They liked the hype, they liked the novelty, and I think that reflects in the responses. There's then naturally, as there often is with quality improvement methodology, a drop-off without any reinforcement initially. And then you can see in weeks 5 to 8 around Christmas time, it turned out that there was certainly a change in clinical need, a change in staffing level, and as a result, less training was able to take place for one, and also we were less engaged with that part of our training. I then at week 8 spotted the problem and started to then distribute the feedback summaries to trainees to show that their efforts were welcome and that they were gaining something from their teaching, and that made a small bonus over a couple of weeks of a few returns on the forms. And then again in week 11, a detection that things weren't going quite so well, as you can see, and so I sent out more messaging onto the WhatsApp groups just to try and keep motivation and engagement at a high, which made a bit of a difference, I think you can probably agree, even though small. So overall, I think the project achieved what I'd aimed it to, which was to increase quantity of feedback from the numerical data I presented, and also the quality of feedback for trainees, which was ultimately from testimonials about how they felt about the information they were given after the teaching. There were a small number overall, but I think most of that's accountable by the day-to-day challenges of working in critical care, either rotating doctors, shift patterns, clinical need, all of those things take an impact in our training. And it was particularly hard for us to do that every day. I hope in the future we'll be able to make all of the topics learner focused so that at least every trainee can choose what they teach for their benefit and for their peers, and ultimately produce some more qualitative data, generate some themes amongst those, and then potentially produce some form of research about exactly what trainees get out of their daily teaching, because we think it's great, but maybe it's not. I would love to see this rolled out a bit more, something equally fun, I suppose, in the COVID scenario, but also in other clinical areas. And I'd love you to try and get on board with that if that was something you liked to do. So in summary, the teaching tombola was simply designed to be a fun, experimental solution to the everyday challenge we have with gaining feedback for our trainees. And hopefully, I think it achieved this. It's simple, cost-effective, low resource, and I think using similar ideas to adapt our current training styles to the more challenging emerging climate that we now work within will make us all happier and more fulfilled in our day-to-day work. So diolch yn fawr for the Welsh amongst you. Thank you very much, and I'm happy to take any questions.
Very much, Alice. That was really good. Did you tell us what sort of topics you covered?
No, so it was variable. They were mostly aligned to critical care, acute presentations to A&E, vasopressor support, ventilation settings, that kind of thing. And most were delivered by PowerPoint, which again is not my favourite thing as an educationalist, but that was generally how it was focused on critical care rather than other things.
And you talked about feedback, the sort of feedback that people were getting. As we all know, people react very well to positive feedback, but getting feedback that's less positive and delivering that in a way that is constructive and helpful, what were you getting feedback that was less good, and how did people cope with that?
Yeah, so intentionally the way I designed the questionnaire was with that in mind. So the 3 questions were: what was good, what could be improved rather than what was bad, and then a free commitment of, is there anything you would like to see again or more of, rather than what was rubbish and what would you do differently yourself.
Great. There's a question from Dr. Scriven as well, who said, did all this good work impact in any way on the consultants? Did they disappear from this type of work?
Interesting, yes. Generally, the consultant body was very dynamic and keen for change. So in terms of supporting us to do that, they were very much on board. If there was something small that could wait clinically, they would give us that time to do what we were doing. And they were very happy for me to put posters up and stickers and shoe boxes everywhere. So I think they were keen for us to improve for their benefit, so that we were in well-being and happy people by learning every day.
And did they help with any of the learning?
Yes, so Dr. Holmes stepped in a few times to help us when we weren't available or we were off sick or missed a session, but it wasn't specifically consultant-led, no.
Lovely. Thank you very much, Alice. That was really good. And we seem to have solved our technical issues, which is also fabulous.
Thanks.
So now we are going to the next presentation. This is a pre-recorded presentation, so if anybody has any questions, please type them in the Q&A box and we will get written answers for you as soon as we can. So the next speaker is called Madhar Iqbal, and she's a CMT in Norfolk and Norwich.
Good evening, everyone, and welcome to today's evening meeting. My name is Madhar Iqbal. I'm one of the core medical trainees. First of all, I would like to thank the Society of Acute Medicine for providing me this opportunity and platform to present my abstract. The topic for my today's presentation is a rare cardiac incidentaloma, an unusual mass at an unusual site. This is a case of a 75-year-old female with a history of worsening exercise tolerance, breathlessness on exertion and ankle edema. She was referred by her GP for an outpatient echocardiography and cardiac assessment. Her pro-BNP was 536. She had a past medical history of COPD, hypertension and angina. She was taking salbutamol inhaler, bisoprolol 2.5 once a day, isosorbide mononitrate 30 mg once a day, ramipril 5 mg once a day, simvastatin 20 mg at night, and GTN spray. Her observations were stable, with a blood pressure of 160/70, respiratory rate of 18 per minute, heart rate of 72 per minute, and she was afebrile. Her ECG showed sinus rhythm with left axis deviation. Her echocardiography showed a pedunculated mass measuring 1.3 into 1.3 centimeters at the left ventricular outflow tract, with a severely dilated left atrium, normal LV systolic function with an ejection fraction of 65%. She had moderate diastolic dysfunction with mild aortic sclerosis. She was admitted to the hospital and was referred to the Cardiothoracic Tertiary Center, Papworth Hospital, where she had excision biopsy of the mass, which was sent for the histological examination. The histology report of the mass confirmed it as a benign papillary fibroelastoma with fatty deposits. This slide shows a brief overview of cardiac tumors. Cardiac tumors can be divided into benign, malignant, and cystic categories. Atrial myxomas are the most common primary cardiac tumors, 80% of which are benign and 30% present with asymptomatic features. Amongst the malignant cardiac tumors, angiosarcomas and rhabdomyosarcomas are the most common primary malignant tumors of the heart. When investigating a cardiac tumor or a mass, a multimodality approach using an echocardiogram and histology is essential to reach the diagnosis. And the goals of the investigation should be: is there a cardiac tumor? What is the location and extent of the tumor? Is it benign or malignant? Now discussing a bit about our case, which is papillary fibroelastoma. Papillary fibroelastomas are the second most common primary cardiac tumors. Their most common sites include the left heart. They're usually benign in nature and their size may vary from 2 millimeters to 70 millimeters. 80% of them are found at the mitral valve surfaces, and they can cause embolization, syncopal attacks by impairing the blood flow across the valves. Cardiac MR has a significant role to play in evaluation of such patients, and histology remains the gold standard for diagnosis. The unusuality in our case was the tumor was not attached to the valve, it was larger than the typical descriptions, and it was located at the LVOT. For further reading, I would like to suggest the following references. This is the last slide of my presentation, and the key learning points are: we have to keep an open mind when suspecting heart failure. Masses in the heart need early cardiac review. An early echocardiography can be very helpful in reaching the diagnosis in time. Tumor of heart are not always myxomas, and histology is needed to rule out malignancy. With this, I conclude my today's presentation. Thanks again, and have a very good evening.
Well, thanks to Mariha, who's not with us in person, for that unusual presentation of a cardiac mass. And I guess as we are all doing more famous, and I don't say hocus pocus, pocus is the word I'm looking for, then I guess we're going to find more and more incidental omas and things that we need to possibly look at or just leave be. Our next speakers are going to talk about what the bleep, which is fun for me because anybody who knows me really well in person knows that I'm quite sweary. So Richard and Cleona did a joint project together. Richard is going to present the talk for us, and then Cleona is going to be around to answer questions. Cleona is an F2 in Bristol, and Richard is an F2 at the Royal University Hospital in Bath. So I'm going to hand over to Richard, and then we will let Cleona in as well. So Richard, don't forget to click on your screen first, and then you can use your arrow keys to move your slides forward, and welcome.
Thanks very much for having us. So our project was called What the Bleep, I hope you can hear me. And this was conducted at Musgrove Park Hospital, Taunton, where we were both F1s there and colleagues together. Ooh. There we go. So I wanted to start with a quote. So this quote says, "I was assessing an acutely unwell patient with neutropenic sepsis on the oncology ward. I was interrupted by a fast bleep to a ward on the other side of the hospital. I attended immediately. The patient was well with normal observations who required a re-prescription of routine paracetamol. I had no ability to triage this, and it was completely inappropriate." So this highlights the problem with the current bleep system at Musgrove Park Hospital. This junior doctor was assessing someone who needed immediate resuscitation, and instead of being able to do that, they were interrupted by a bleep, which arguably may have been more urgent, but instead it was a routine job that they obviously put their current patient at risk. We realised this was a major problem, and we realised that a lot of jobs were inappropriate, as we deemed it, for the out-of-hours setting, and were preventing from juniors from attending unwell patients and effectively prioritising tasks. So we collected data from Switchboard of the total number of bleeps, and we found on average the out-of-hours doctor gets a bleep every 19.2 minutes during a 24-hour period. We then stratified these bleeps by designing a handover sheet and giving them to all juniors that were due to be on call in the following few weeks when we collected data. And that allowed us to see exactly what jobs they were getting, because there was no auditable data on the actual content of the jobs each junior doctor was receiving on call up until that point. We found that over a third were deemed by us as not necessary for an out-of-hours setting. Obviously, these are jobs that should be completed, but they were preventing the junior doctors from attending unwell patients and were more routine jobs that should have been completed during the day. And these jobs included things such as routine medication prescriptions such as warfarin, not stipulating on fluid prescription charts whether the fluids should be reviewed, stopped or continued at the end of the bag. And often these fluids would run out at 3 in the morning, resulting in an immediate bleep to the on-call staff. And other jobs such as completing and filling out drug charts and preparing for the weekend. We also use semi-structured interviews for qualitative data, as you can see from our initial quote. And we aim to reduce the average number of bleeps made to the on-call junior doctor by 10% over a 3-month period. We didn't do this across the whole hospital. We focused on one ward, which had a disproportionate number of bleeps compared to all the other wards in the hospital, so as to not spread ourselves too thin. We used QI methodology to guide plan, do, study, act cycles, guided from our semi-structured interviews and also the records of bleeps I mentioned before. Our plan, do, study, act cycles were a nursing staff logbook that was kept by the telephone on the target ward. This was to encourage a think before you bleep culture for nursing staff. So they had to record exactly what job was requested for the on-call in the book. And it was hoped that this would not only provide more data on which jobs they were requesting out of hours, but also encourage them to think before you bleep and perhaps consult with a senior nurse on the ward, perhaps the sister in charge, and perhaps these routine queries might have been resolved that way. Our second was a ward-based education session aimed at junior doctors, and this was to target fluid prescriptions, routine medication prescriptions, and also generally improving the efficiency and prioritisation of junior doctors during the day. So those routine jobs were not handed over, or the ward team out of hours were not bothered, therefore affecting patient care. And we also designed a poster aimed at juniors to encourage them to complete routine jobs during the day and reminding them of those jobs that I just specified. And especially this was drug charts at the weekend that weren't often completed prior to the weekend. And then someone out of hours might have to rewrite 2 drug charts and not attend to an unwell patient. We collected bleep frequency before and after each cycle. This is our rung chart. As you can see, on the y-axis we have the number of bleeps, on the x we have time. We can see our baseline data based on the handover sheet on the left. And after each cycle, you can see that there was a reduction in the number of bleeps that was received from this target ward. You can also see that the total number of bleeps does not significantly decrease from before and after our project finished. And this perhaps reflects the premise that it's quite difficult to influence bleep culture overall, and that it needs further interventions, and it was perhaps a bigger project than we initially anticipated. So that doesn't mean that our project was not a success. We showed that there was a high volume of out-of-hours bleeps, which was a patient safety issue, as seen by the initial quote and other qualitative data that we also collected. We found a significant number of these bleeps were preventable, and this requires an MDT input to address doctors, nurses, and ward staff. Our cycles demonstrated short-term improvements, but as I say, the reduction in the total number of bleeps received was difficult. Our project was the first that provided auditable data on out-of-hours bleeps in Musgrave Park Hospital, and this has directly led into a hospital night project, which I'll talk about on the next slide, because before this we had no idea of what the exact content of each bleep was. Our team also suggested that a formal trust induction session to new F1s would be a good idea, and this is focusing on job prioritisation, and we didn't want a new intake of juniors as we were when we started in Musgrave Park, and we didn't know about kind of this job prioritisation preventing these routine jobs being handed over to the out-of-hours team, and we wanted to prevent that for the new intake of F1s, so we thought that would be useful. Going on to hospital at night. So this is an ongoing trust-wide project at Musgrave Park Hospital. It's focused on data collection on out-of-hours jobs. Our data directly led into this with the idea that out-of-hours routine jobs were being handed over out of hours and affecting patient care. And essentially this project has developed a digital task allocation system, which is in use in other hospitals, with an accompanying outreach coordinator. And this is to digitalize bleeps and triage them on a kind of routine kind of needs review and then an urgent basis. The outreach coordinator would then allocate these to juniors that were on that shift. This has been trialled with some success prior to the COVID pandemic, but obviously that's halted that being kind of rolled out across the board. And at the moment where we are with that is that they're awaiting formal hospital committee investment for an ongoing service such as what I've just described. There were a couple of limitations on our data. Obviously, there was a number of confounding factors that would have affected our RUD chart, such as variations in hospital capacity, and also this is seasonal as well. So, you know, you might not always see the line going down, but I think we showed that obviously each intervention did reduce the number of bleeps, although overall we didn't see the number decrease significantly. And also it was a small data set, so we were unable to validate our findings with p values and confidence intervals. But obviously this is something that can be addressed with collecting more data going forward in the Hospital at Night project. So I'm not sure how we're doing for time, but we're ready for questions now.
That was perfect. Thank you, Richard. And we should just say that you are in the same room, but you live in the same household, just in case anybody is going to mention social distancing, which obviously we all know is really important. That was really good. And listening to you and your solutions and what's happening in your hospital is really good. But I also find it quite frustrating that the NHS in general, sort of, these projects happen in different hospitals for the same reasons, and we're sort of reinventing the wheel over and over again. Sorry, my dog is having a moment. So I don't know how we can get around that, and I don't have any thoughts, but we've got something very similar in our hospital. We have a hospital out of hours programme where all the bleeps get sent to the coordinator, and it's actually transformed the junior doctors' lives, because you can reject the bleep in inverted commas if it's inappropriate, or you can pass it on to someone more senior or more junior, however you want to do it. What do you think about how, why are we having to reinvent these things, and why doesn't the NHS sort of work all together? It's a bit of a philosophical question, but
yeah, well, it's really difficult, and it's quite interesting because the project was actually ignited by so we were working in a Somerset hospital, and the other hospital in Somerset had actually replaced the bleep system with sort of very old school phone technology. So you were able to get text messages and you could get calls, and to us that seemed a lot more logical, because you could essentially triage in a very basic format your tasks, and you knew that if you were with a patient you could look at the phone and you knew the vague content of what you were being asked to divert your attention for. So we sort of wanted to copy that. And then it did dawn to us that, yes, this is something that needs to be addressed probably throughout the whole of the NHS. There are conferences, I believe there's a Hospital at Night conference where people from trusts up and down the country go to discuss this, but I'm not quite sure why it hasn't been addressed. I think we get a lot of stuff in the news about how bleeps are archaic, and some places have thrown out the system but other trusts keep with it. Why it's not centralised, I don't know, but I for one will be a big proponent of getting more data and more publicity around it, because yeah, it's an issue for everyone and we know it.
So someone has put in the chat box, I'm trying to double T, that Leicester has replaced bleeps with nerve centre.
Yeah.
And smartphones, so that goes in red, amber and green, so you get to be able to prioritize your bleeps, which is a good idea. And there's a bit of chat about phantom bleeps, because there's nothing worse than answering your bleeps.
Yeah. And so we recorded that. I wish we could show you all the data, but yeah, even just the numbers of bleeps where it would be bleep 3 times from the same number, and that in itself is just it's sort of dangerous really, because you don't know what you can be interrupting to try and chase down that bleep. Yeah. And
it would be also an interesting bit of work to carry on if you could be bothered to look at bleeps for the MedReg.
Yeah.
There is Twitter feed about med registrars and what they get bleeped for. And when I was a MedReg, I got bleeped once because there was a bat in the ward, and they wanted the MedReg to get rid of it. So you've got that to look forward to when you are the MedReg. Thank you very much. That was really good. And so I am going to go on to our last few slides now. So hopefully I can manage to work the keyboard. We're going to have the same questions that we had before, please, just to see whether we have managed to inform you a little bit. So can we have the first question, Tim? Can you now rate your understanding of the implications of acute oncology, and particularly about neutropenic sepsis as an ambulatory condition, I guess? See what you think of that now, please. And let's have the answers, Tim. So, we did a good job, very good. Thank you. And the next question is about apps. So what do we think about apps in acute oncology, and have we learned something now? My dog is an excellent guard dog, I'm very sorry. Let's have the answers, Tim. So again, we all understand a little bit more about that, which is really good. So last question, we have 2 more seminars booked. We are going to a slightly slower pace than weekly after this one. So let us know, would you like to attend? Clearly, we'd be very interested in ideas for people about what they want to hear in the future as well. So that's brilliant that lots of you want us to continue. Like I said before, I'm really sorry about the technical issues we've had tonight. We haven't been quite as smooth as we have been over previous weeks. But it's still a learning process for us as well, and there's an awful lot of work goes on behind the scenes. And I'd just like to highlight that, and our technical team, including Tim and Christine and Eloise, who put in a massive amount of work behind the scenes for us. So these are the times that you have to remember to join us again, because we are going away from the weekly ones now. So the next one is on the 7th of July, again starting at 7 o'clock in the evening, and that's going to be a bit of a themed one, and we're going to be looking at the outpatient treatment of COVID-19 and having views from acute medics and an emergency department who started looking after their patients from an ambulatory care point of view. And so we will be getting some interesting statistics from that, I hope. And then a further one before we go off for the summer in the 18th of August. If you would like to see anything on the programme, have any ideas, or indeed have anything that you want us to give you an opportunity to present, please get in contact with us. If you want to register or get any of your friends to register for our talks, you can see on the website you can register for the webinar, but also you can find addresses on how to contact us on there. So if you want to contact us with ideas, please do. We are always grateful for your input. So we're going to finish a little bit early tonight. If you've got any questions for Madhar, we will make sure they get answered. I'd like to really thank you all for joining again, and we will hope to see you all on the 7th of July. Take care until then. Thank you.